I want to introduce Adelaida Castro-Sanchez, who's here with us from Spain. She's a physiotherapist, and she's a professor at the University of Elmira, Spain. She has a background in nursing. She also has a background in social and cultural anthropology. She has a doctorate degree in physical activity and health, and we've invited her to present her work she's done on persons with multiple sclerosis. And would you please help me introduce her? Thank
you very much for your presentation. Then I'm going to speak about a study of hydrotherapy that our research group has developed in patients with multiple sclerosis. As you know, multiple sclerosis is a chronic demyelinating neurological disease afflicting young and middle-aged adults that impedes coordination, strength, cognition, and sensation. Although treatment with immunomodulatory agents can affect the course of the multiple sclerosis, it is not guaranteeable. It is the most frequent disabling neurologic disease among young and middle-aged adults in North America and Europe. Many multiple sclerosis patients reported that they use CAM, complementary and alternative medicines, due to dissatisfaction with their conventional pharmacological therapies, and these patients reported that they have important benefits with their alternative therapies. Although physical therapies are widely used by multiple sclerosis patients, there is no scientific evidence to support its effectiveness. Multiple sclerosis patients use alternative therapies alongside with their conventional medicine, mainly pharmacological treatment. It's well known that female multiple sclerosis patients and those with higher education and income are more likely to use physical therapies. And the severity of the disease also may influence in the use of CAM. A recent guideline from the National Institute of Health and Clinical Excellence affirmed that multiple sclerosis patients should be informed of findings on the benefits of certain approaches, but declare that insufficient evidence is available to make a formal recommendation. Named techniques include reflexology, massage, multimodal therapy, fish oils, magnetic field therapy, massage plus body work, neural therapy, and the patients also reported the therapeutic benefits for exercise, vitamins, herbal, mineral supplements, relaxation techniques, acupuncture, cannabis, and massage, mainly for the treatment of pain, fatigue, and stress. Maloney reported that Tai Chi, meditation, and hypnotherapy improve quality of life and reduce pain in patients with multiple sclerosis by interfering pain conduction, producing analgesia through nociceptive pathways. There are only 2 studies on the effectiveness of aquatic exercise in patients with multiple sclerosis. The study by Salem and collaborators, and the study that I'm going to present at this moment. Hydrotherapy is frequently applied to patients with painful neurological or musculoskeletal alterations because the heat and floatability of the water block nociceptors by the acting on thermal receptors and mechanoreceptors and exert a positive effect on spinal segmental mechanism. Warm water increases blood flow, helping to dissipate allogenic chemicals and enhance muscle relaxation. Finally, hydrostatic effect of water can alleviate pain by reducing peripheral edema and sympathetic nervous system activity. In a review over crenobalneotherapy in patients with limb osteoarthritis, Forrester and François found that crenobalneotherapy improved pain, quality of life, and function in patients with limb osteoarthritis. Our research group developed a study to determine the effectiveness of IT exercise protocol in swimming pool to modify pain, quality of life, disability, impact of multiple sclerosis symptoms, fatigue, and depression. This study was developed because we had previously developed a study on the effectiveness of IT aquatic exercise on fibromyalgia patients. And these patients reduced pain and improved their quality of life with the aquatic IT exercises. And then, based on that, we decided to develop another study in patients with another chronic diseases such as multiple sclerosis. We perform an experimental control trial based on randomized control trial with a multiple sclerosis with a control group, multiple sclerosis patients undergoing a relaxation program in a therapy room, and with an experimental group, multiple sclerosis patients underwent or receiving IT exercise program in swimming pool. Patients were subject for the Multiple Sclerosis Association of Almeria, and among 198 multiple sclerosis patients assessed for eligibility, 98 did not meet inclusion criteria and 27 refused to participate. Remaining 76 patients assessed at baseline randomized in two groups, IT exercise group and relaxation group. Informed consent was obtained for each patient before entering in the study according to Helsinki Declaration, and all patients were evaluated at baseline and after the last treatment session at week 20 and at week 24 and at week 30 by a researcher blinded to group allocation. All patients receive treatment sessions twice a week for 20 weeks, on Monday and Thursday for the experimental group patients, and on Thursday and Fridays for the control group. Power calculations were carried out after 20 patients had been treated, estimating a minimal sample size of 33 patients per group for a power of 80%. The protocol of this study was the following. At the beginning of the study, we performed a patient selection with a final study sample comprised 71 patients with multiple sclerosis. After, we register data logging, age, times since diagnosis, course of the disease, VUS pain level, and expanded disability scale. After, we perform or follow by outcome assessment baseline, intervention, and finally, we perform outcome assessment immediately and 4 and 10 weeks after the treatment period. The selection groups was balanced for type medication received using a stratification system that generates a sequence letter for each combination of categories. Each patient was assigned a sequence of letters according to the type of medication they were receiving and placed in a sealed envelopes that were randomly assigned to each study group. Single-blinded was warranted because outcome assessments were evaluated by our researchers blinded to group allocation. IT exercises were conducted in a swimming pool with a water temperature of 36 degrees. Patient took a shower before entering the pool with a water temperature of 35.5 degrees. And a single physiotherapist led all IT sessions, teaching the 16 movements that constitute this therapy, which requires no additional material. All exercises were performed with shortly tapped water, breathing and slow, broad movements on arms, legs, and torso to work on balance, flexibility, strength, and breathing. And there was a maximum of 10 participants per session. And now you are going to watch a short time video. The 16 movements in I Ching are designated as follows: contemplating, floating, uplifting, enclosing, folding, soothing, gathering, grouping, freeing, shifting, flowing, reflecting, accepting, accepting with grace, rounding, and balancing. In the video, you want to repeat every movement. Sorry. Relaxation is induced by the wide and slow movements of arm, legs, and by the focus on the breathing. The principles of I Ching are yuan, circular movements seeking internal and external harmony; Shang, internal and external relaxation to promote blood circulation; Zhong, movement at given speed that is always controlled by the mind; Sheng, correct maintenance of balance and postures; Xing, absence of tension in the body; Tixing, direction of through towards the mind concentration; and Xia, easy, comfortable, and relaxed movement of the body. Relaxing the Chi Music album by Oliver Santi and Friends was played during the sessions, which lasted 60 minutes, beginning and ending with 10 minutes relaxation in the water. During these 10 minutes, patients perform abdominal breathing simultaneous with contraction relaxation exercise of muscle groups in hands, arms, shoulders, face, neck, thighs, legs, and feet while standing in shoulder depth water. Exercise in the control group were conducted in a therapy room with a high temperature of 26 degrees, and no ambient music was played to the patients during the control sessions. These patients underwent the same exercise protocol that patients received in the experimental group, but these exercises were adapted for these patients because some patients or some multiple sclerosis patients cannot standing up. For this reason, these exercises were held in supine position with abdominal breathing plus guided contraction and relaxation. In this study, the level of pain was measured with the McGill Pain Questionnaire. It is it is a multidimensional. It is based on a multidimensional perception of pain. With 4 dimensions: sensory, affective, evaluative, and miscellaneous. The sum of the RAM value is the pain rating index, and the pain present index is based on a scale to 1 to 5 points. And it also includes a visual analog scale with a human figure or with a representation of the human figure where the patient which indicate the exact localization of pain. The disability was measured with the Roland Morris Disability Questionnaire. It is a self-administered disability measurement with a score between 0 to 24 points, where 0 points correspond to no disability and 24 points correspond to severe disability. Spasm VUS was measured with the Spasm VUS scale, where 0 points correspond to no spasm and 10 points corresponds to the worst spasm imaginable. The impact of multiple sclerosis symptoms was measured with the Multiple Sclerosis Impact Scale 29, with 2 dimensions, physical and psychological, with a score between 0 to 100 points. Total higher score indicates more impact of symptoms. Fatigue impact were measured with the Modified Fatigue Impact Scale with 3 dimensions, physical, cognitive, and psychosocial. Also, in the analysis of the fatigue, we use the fatigue severity scale. It's a scale with a score between 1 to 7 points, where 1 point corresponds to no severe fatigue and 7 points correspond to severe fatigue maximum. And the state of depression was measured with the Beck Depression Inventory. It includes 21 questions with a score between 0 to 73 points, and total higher score indicate more severe depressive symptoms. Person daily functioning were measured with the Barthel Index. This index includes 10 items with a score between 0 to 100 points, and in this case, total higher score indicate more independence. Data treatment and statistical analysis were analyzed with the SPSS version 18.0. With a descriptive analysis, means standard deviation and percent of change. The distribution of variables was analyzed with the Kolmogorov-Smirnov test, and the qualitative variables were analyzed with chi-square goodness of fit test. Variance change in the outcome measurements were analyzed with a separate 2x4, 2 groups, and 4 time points, baseline at 20, 24, and 30, a mixed model analysis of variance with repeated measurement. And within groups change were analyzed with a pair t-test or a student t-test. A p-value less than 0.05 was considered significant in all cases. The final study sample comprised 71 patients, 36 patients in the experimental group, and 35 patients in the control group. And at baseline, the patients did not differ in demographic characteristics. In this study, patients most frequently reported their worst pain to be musculoskeletal pain, lumbar pain, neck pain, pain in legs, feet, arms, shoulders, and forearms. And no significant differences were found in pain anatomic distribution between groups. In VUS pain at week 20, the IG group showed a significant reduction in pain VUS score baseline at weeks 24 and 30, and the group significantly differed in pain VUS scores at weeks 20 and 24. The relaxation group showed no significant differences. For McGill Pain Questionnaire for pain rating index dimension, the IG group showed a significant pain reduction at weeks 20 and 24 versus baseline, and the group significantly differed on these time points. The relaxation group showed no significant difference. For pain present index dimension, the IG group showed a significant reduction at week 20, and the relaxation group showed no significant difference, and no significant difference between groups were observed at any time points. In the Roland Morris Disability Questionnaire, significant decreases in scores were found in both groups at week 20 and 24, and in the IG groups alone at week 30. Significant differences between groups were found at weeks 20, 24, and 30. In Spatial VUS, the IG group showed a significant decrease in Spatial VUS score at week 20 that was maintained at week 24 but not at week 30. The relaxation group showed no significant difference, and the group significantly differ in Spatial VUS at weeks 20 and 24. In multiple sclerosis impact scale 29, for psychological dimension, both groups show a significant reduction at week 20 that was maintained in IG group at weeks 20, 24, and 30. there were significant differences between study groups at week 20, 24, and 30. For physical dimension, the IQ group showed a significant score reduction at week 20 that was maintained at weeks 24 and 30. And the relaxation group showed no significant difference. There were significant differences between study groups at week 20, 24, and 30. For modifying fatigue impact scale, in physical dimension, the IQ group showed a significant score reduction at week 20 and at week 24, and the relaxation group showed no significant differences. The groups significantly differ at week 20 and 24. For cognitive dimensions, the IQ group showed a significant reduction at week 20 and at week 24, and the relaxation group and between groups showed no significant differences. In psychological dimension, the IQ group showed a significant score reduction at week 20 and 24, and the relaxation group and between groups showed no significant differences. For fatigue severity scale, the IQ group showed a significant reduction in fatigue at weeks 20 and 24. The relaxation group showed no significant differences versus baseline at any time points. The groups significantly differ in scores at week 24. In back depression inventory, the IQ group showed a significant reduction at week 20 and 24, and the relaxation group showed no significant differences versus baseline at any time points. The groups significantly differ in scores at weeks 20 and 24. Finally, for the Barthel Index, the IQ group showed a significant reduction at week 20 and 24, and the relaxation group showed no significant differences versus baselines at any time points. No significant difference was found between groups at any time points. These results are agreement with findings in pain reduction and mobility improvements in other patient population undergoing aquatic exercise. Our results are agree with the study by Kamioka and collaborators in the quality of the systematic reviews over aquatic exercise and value therapy on locomotor diseases. And in this review, the patients found a short-term effect of aquatic exercise and value therapy on locomotor diseases. In the meta-analysis by Snook and Mort over exercise training on walking mobility in multiple sclerosis patients, these authors conclude that exercise training is associated with a small improvement in walking mobility among individuals with multiple sclerosis. Our results are disagreed with the results in the study by Hall and collaborators over aquatic exercise in neurology and musculoskeletal disorder or diseases. These authors did not find differences in pain relief between aquatic and land exercise. Our study and the study by Salem and collaborators are the only two studies over aquatic exercise on the effectiveness of aquatic exercise in patients with multiple sclerosis. Salem and collaborators in this study, it is a pilot study with 11 subjects. These authors perform a community-based aquatic exercise program, mainly with aerobic exercise and strength exercise, or in patients with multiple sclerosis. And these authors conclude a patient receive twice a week. A patient receive treatment session twice a week for 6 weeks in this study. And these authors conclude that aquatic exercise is feasible and resulted in improvement in motor function of individuals with multiple sclerosis. Spasticity, which has a major impact on overall disability in multiple sclerosis patients, improved by aquatic exercise because patients are able to perform wider voluntary movements while immersed in water, and it has a positive impact on fatigue. Ambient music may contribute to the positive effect of the Aichi sessions by increasing motivation and distracting participants. According with a pilot study by Conklin and collaborators, a home-based working program using rhythmic auditory stimulation improved gaits in multiple sclerosis patients because music promotes natural rhythmic movements in the water, enhancing mobility and exercises. In two meta-analyses by Snook and Molt and collaborators, and in a systematic review by Riedberg and collaborators, exercise training is associated with an improvement in activity-related and working mobility in multiple sclerosis patients. And all these authors conclude that exercise is associated with physical and psychological health benefits and reduce cardiovascular disease, diabetes, depression, and cancer. According to Kamioka and collaborators, patients with multiple sclerosis should be encouraged to engage in exercise as an adjuvant therapy to mitigate progressive mobility impairment, especially given the prevalence of physical inactivity in these patients. And the Aichi Aquatic program offers benefits in the treatment of neural and musculoskeletal diseases that may not be obtained with hydrotherapy modalities with only passive immersion. According with Snook and Molt, Broach and Dattilo, exercise therapy improves mobility in all types of multiple sclerosis, especially in primary progressive and secondary progressive multiple sclerosis because in these states, pharmacological treatment is minimally effective, and these patients report that they turn to another complementary therapies to the pharmacological treatment for improve their mobility and reduce the disease progression. According with the study by Calandre and collaborators over a 6 weeks Aichi Aquatic exercise program and stretching exercise in fibromyalgia patients, we found a reduction in pain and quality of sleep that lasted 4 and 12 weeks after treatment. But our results in this study are disagree for the state of depression, fatigue, and mental health, because Aichi program achieved a significant reduction in depression and fatigue, but not in fibromyalgia patients. According with the study by Apple and collaborators, exercise therapy is the most CAM used in physical therapy, and the patients also reported the therapeutic benefits of vitamins, minerals, and other supplements added to the physical therapy. Apple and collaborators in the previous years conclude that not effects or slight improvements in multiple sclerosis symptoms have been not reported for electrotherapy, gemstone therapy, hematogen oxidation therapy, homeopathy, psychotherapy, and auxil therapy. Finally, according with Nayak, Berman, and collaborators in multiple sclerosis patients, most frequently reported benefits of physical therapies were relaxation, improved sleep, pain reduction, spasm reduction, muscle strength, mobility, and general well-being. The study limitations in this work include absence of an IG group without ambient music, absence of a control relaxation group with ambient music to explore the contribution of this element, and also the experimental and control sessions were held on different days of week. The participants were not blinded to the nature of their groups because they were all members of the same associations, which may have favored an overestimation of the effects of the IG program. In conclusion, a 20 weeks IG aquatic exercise program produced a significant pain reduction in multiple sclerosis patients that lasts for 10 weeks after the end of the program. It also improves other multiple sclerosis-related symptoms, including disability, depression, and fatigue. These effects of the IG aquatic program were superior to those of an equivalent exercise program in a therapy room.
In the Barthel Index score, it did not appear that there was a great deal of difference between the two groups. What is the minimal clinical difference in the Barthel? I don't know that. I don't remember that.
There is a minimal change, but the Barthel Index measures mainly mobility and activities of the day living. And total higher score indicate more independence from 0 to 100, but a minimally statistic of points, for example, in Roland Morris, are 5 points. A change more 5 points is statistically significant or significant differences, but in Barthel Index is not established.
So it didn't appear to me that on the Barthel that there was much difference between the two, between your relaxation group and the aquatic group. Am I accurate? Am I remembering that correctly?
Yes, there is significant differences. Yeah.
I have a question. You may have said that about the choice for your control group of your intervention was the relaxation, and they stayed in the supine position the whole time.
Yes.
And what was your reason for choosing that as the control group intervention?
The intervention in the control group were exercised with contraction relaxations by the focus on the breathing. But the exercise were mainly aerobic exercise because some multiple sclerosis patients in the secondary progressive state cannot standing up. For the reason these patients cannot standing up, you have to work with supine positions.
But they were exercising. They were doing supine.
Yes, 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 yes. But it's not the same because the aquatic music is not the same.
Your 27 folks that decided not to join in.
27
You had 27
degrees.
27 folks who said
Received.
not going to participate. Why do you think they chose not to?
Normally, the patients, multiple sclerosis patients, need their family to move to the university. And sometimes, if you live in another part of the city or you are alone with a care, and it's impossible to go to university for the treatment sessions. And the treatment sessions were twice a week. Sometimes it's not possible in this study. If you go to the association, the Multiple Sclerosis Association is in the city center, but the university is not in the city center. It's 2 kilometers from our area.
What was the temperature of the water?
36 degrees, but centigrade.
Any problems with overheating or with the patients that were in the IG group with getting too warm?
It's better warm water because if you don't work with warm water is needed for the spasticity. Because if you move with warm water, improve very much the spasticity. It's very important.
But some patients with multiple sclerosis do not tolerate even that degree of warmth. Some of my multiple sclerosis patients would far prefer a cooler temperature. Did you experience that?
No, I don't know. I don't know because they don't like the cool water. If you put in good water, and there is a study, the patient don't go to the good water. They want warm water.
Anecdotally, people who don't want heat in the air, but they want the warm water. And they don't like hot outside. They felt better in the warm water.
Yes, it's better for the spasticity because the major problem is the spasticity.
Although I've had patients that have, while they like getting into the warm water, their feeling of exhaustion after getting out is very substantial. And oftentimes they get essentially vasovagal collapse almost afterwards.
Were they very active in the water?
Sometimes not. Very active, no. None were very active.
The IT is very slow.
Because
Yes, I know.
it's very slow movement because I can't read the video. It's very slow movements, and the 16 movements are in the video. Sorry.
No, and I think it's a beautiful program for folks with multiple sclerosis or fibromyalgia.
Yes.
I like it, but I have had folks that with multiple sclerosis that simply are not comfortable tolerating temperatures at that level.
Yes.
What was the total time duration if they were in the pool? Were they doing, what was the total time duration if they were in the pool? Were they doing independent breathing and then how long did I choose?
Took a shower with 35.5 degrees, and the water is 36 degrees for change a liter for 1 water.
How long were they in the pool? How long was your pool?
How long? 60 minutes. 60 minutes. No, 10 minutes beginning and ending. Okay, with breathing, with slow movements, but the IT exercise exactly 40 minutes. Okay, and in the study, all sessions were 40 sessions, twice a week for 20 weeks, 40 sessions. Beginning and ending with 10 minutes. Okay, for breathing and slow. But IT exercise 40 minutes.
All your moves of the IT are in your handout, so it's in the
Yes.
background.
Yeah.
Yeah.
Okay.
Thank you very much.